The routine immunization schedule helps ensure that every Filipino child receives vaccines at the right time, in the right sequence, and with proper documentation. As nurses, our role is not only to administer vaccines, but also to educate caregivers, monitor compliance, and record accurately to support public health surveillance. At birth, two vaccines are given: BCG intradermally for tuberculosis prevention and hepatitis B birth dose administered within 24 hours to prevent perinatal transmission. After vaccination, provide immediate postpartum counseling to mothers about follow up visits and the importance of completing the full series. Documentation is essential. Record doses in the Early Childhood Care and Development Card or the ECCD card and in the Target Client List or the TCL to ensure accurate tracking. At 6 weeks old, the infant receives the first set of multiple vaccines: DPT1, OPV1, HIB1, PCV1, and rotavirus 1, depending on the DOH current inclusion. Before administration, perform screening for contraindications. For example, check for severe allergies or recent high grade fever. Vaccines may be co administered at different injection sites to maximize coverage in one visit. Educate the caregiver on the next visit schedule and mild common reactions such as fever or localized redness, reassuring them that these are normal immune responses. At 10 weeks old, the child receives the second dose series: DPT2, OPV2, HIB2, PCV2, and rotavirus 2. Before giving these doses, always verify previous vaccinations and update the defaulter list to identify missed children. The second dose must be given 4 weeks after the first dose or the previous dose. Reinforce caregiver education, especially fever management, and explain the importance of reporting any unusual reactions or AEFI, adverse events following immunization. This should be reported promptly to health authorities. At 14 weeks, the infant completes the third dose series: DPT3, OPV3, HIB3, PCV3, and often the hepatitis B third dose. A common mistake is restarting the series when there is a delay. Remember, do not restart. Simply continue remaining doses to complete the schedule. At this visit, perform a comprehensive assessment, including growth monitoring, counseling on infant and young child feeding, or IYCF, and discussing danger signs of illness to support holistic child care. At 9 months, the measles or measles rubella vaccine is administered. Ensure the child meets the eligibility criteria and that the required interval since the last vaccine has passed. Plan outreach activities or micro plans to reach children who may miss their 9th month visit, especially during busy local events like harvests or fiestas. Also prepare for supplemental immunization activities or SIAs to address immunity gaps in areas with lower coverage. Immunization is not just for the infants. Pregnant women are also protected. Tetanus toxoid or TT1 is given as early as possible during pregnancy, followed by TT2 at least 4 weeks later. TT2 provides about 3 years of protection and also protects the newborn against neonatal tetanus. Documentation must be consistent. Record each dose in the maternal record and facility logbook to track coverage and protection. For extended protection, the mother can complete the TT3 to TT5 series, which offers long-term or lifetime protection against tetanus. These doses are integrated into antenatal care or ANC visits and combined with birth planning and promotion of skilled birth delivery. Tracking through maternal registries help reduce missed opportunities to ensure continuous protection for both mother and child. To summarize, the routine immunization schedule or RIS covers the infant series from birth to 9 months, the measles or MR vaccine at 9 months, and the TT1 to TT5 schedule for pregnant women. Service delivery models may include immunization Wednesdays or daily flexible sessions depending on community needs. Finally, there are catch up protocols for children who start late or move between barangays. The key is to ensure no child is left unvaccinated.